Hi, everybody. This is a podcast where a real doctor discusses fake medical emergencies. This means that unless Desmond is your constant, this podcast is not medical advice. If you need medical advice or medical care, please contact your doctor. Also, a quick note before we get into the episode. I made a mistake when I was taking notes. On The Resident, Manish Dayal plays Dr. Devin Pravesh, not Dr. Devin Patel. Sorry for the mix-up.
Hi, everybody. I'm Jackson Vane.
I'm Johnny Kolasinski. You might remember me from such podcasts as Dances with Wolverine, my attempt to write a cinematic universe that includes Kevin Costner.
I thought you were going to make fun of, like, Michigan for losing to Ohio State.
Oh, I absolutely could have done that.
That was what I thought we were going at. I'm not even from Ohio State, and I even know that's, like, the easy joke you could have made right there.
That would have been the better one,
Yep.
but I didn't. This is Hi Everybody, a Bad Medicine podcast. Every week we talk about what Hollywood gets right and wrong about medicine and how the body works.
Yep.
You can find this podcast on Facebook, Instagram, and Twitter at Hi Everybody MD, and on our brand new sparkling website, HiEverybodyMD.com.
Yep. You can also leave us a message or leave us comments, questions, suggestions in the future at 530-DOCTORB. That is 530-362-8672. And remember, the extra B, at least for this week, stands for boy, did this one suck this week.
Oh, Jackson, the B is for broken.
I don't think I've ever been so frustrated and looked at the clock more than for this week's topic.
Yeah, this is one that has been on our list for a while.
Well, we haven't done a medical show yet, and we thought this one might be the way to start.
Yeah, and we hate ourselves.
Oh, yeah.
We hate our lives. Everything is awful.
Yeah.
We are going to be discussing the pilot episode of Fox's The Resident.
Yep, and it is horrendous.
Yeah, it was. I'm not a doctor, guys. I'm not sure if you know this. I might have mentioned that in passing a couple times in some episodes. Even I knew that this was just garbage on a stick.
Yeah, the episode was, 40-something minutes long? And
Yeah.
It took us more than an hour and a half to get through it because I paused so many times.
We paused in the opening scene multiple times. I stopped saying, I'm taking too many notes.
Yeah.
We need to pause here.
Yeah, it hurt. I mean, if you've never seen the show before, it's about this very, I guess, optimistic, bright-eyed, bushy-tailed intern on his first day, at least for the pilot, and then meets this very brash, very quote-unquote seasoned senior resident, and he's paired up with him, which I've never heard of one resident being paired up with another senior resident for the entire duration of their residency. It makes no sense because at some point, that other resident or doctor graduates. It's really hard to be paired up with one person if every year their status is changing.
Right, because then he would need to learn how to be a fellow, or he would get a fellowship somewhere else, or...
Because you graduate at some point. So, but I'm jumping ahead. This whole episode starts in the OR where they're doing an appendectomy, and you can see where we learn the chief of surgery is
bad.
Wrist deep in someone's abdomen to remove an appendix.
Right.
Which is not what you want to do. If you have an appendix that's already kind of swollen and angry, the last thing you want to do is squeeze it. It is going to burst. And that is the biggest complication that we worry about with any kind of appendicitis, is whether or not it's perforated or not. Because just kind of basically explaining what an appendix is, it's just like something that hangs off at the end of your intestine, and that is still connected to your intestine. So if your appendix bursts, whatever's inside of your intestines is now inside your abdominal cavity. So that means you got poop in there. Poop and bacteria.
And the... I'm going to say superbacteria, but that's not the right term, but whatever it is that was infecting your appendix.
Yeah, and usually your appendix, not so much was infected. It could be just because it's swollen, because you got a poop stone in it, called an appendicolith, which can actually cause it to be inflamed and swollen as well. So all of that together can cause a lot of issues.
Okay, so it's generally not
It
not
could be
the
an
infection of the... It's not always an infection of the appendix itself that's the danger in a burst appendix.
Yeah,
it's the fact that you're pooping into your own insides.
You're pooping into your own insides, but also you're at higher risk for getting like abscesses and stuff like that too. So you can actually get septic and just irritate all of your organs, and that will shut down your make your intestines not move really well, and then that'll go into your bloodstream and cause more issues. But most of the time we don't have to cut. I say we in a general term because I'm not a surgeon, but most of the time what surgeons do is they'll do a laparoscopic appendectomy.
Which means they just make a tiny, tiny incision and then send tools in there to do all the work.
Like they use a camera, they blow up the belly. I think
we talked about last week.
We talked about
this 2 weeks ago.
A few weeks ago, yeah, where we blow up the belly, so we can look in there and then, look for the appendix and take it out. It's very minimally invasive. It's not that bloody as you see in that whole thing. But the crazier part was, I think there was another resident in there, and she was doing surgery with the chief, so she was really excited and wanted to take a selfie.
Right.
Which is such a big no-no.
Yeah, that like, just from HIPAA laws, that would be an issue, let alone the sterility and...
You shouldn't be bringing your cell phone, at least not having your cell phone in your pocket or anything like that. Like, yes, we do listen to music inside of the operating room because, you need something to distract. You can't just work in complete silence or anything like that. So hearing music in the OR is not an uncommon thing. But calling the anesthesiologist from behind his drape while he should be monitoring the medications that are given and whatnot to take a picture of everybody in the operating suite is really, really bad form. People have been fired for way less with taking pictures.
Well, that's not the worst thing that happens.
No.
Because while everyone is taking those pictures, Dr. McStupid...
I like to call him Dr. Shaky Hands.
Dr. Shaky Hands gets shaky hands, severs...
Something,
severs a blood-carrying tube.
Yeah, and I think the only tube, if he was, like, really shaky and goes really deep, would be, like, with that much velocity, probably the aorta or something like that. And that would come out, like, with quite great force.
Which it did.
It did. It would also look very bright red, because that's the main highway that comes off of your heart, basically. So then
he would be able to sever something that not voluminous when he was somewhere in the appendix
He
region?
would have cut through... Well, if he did, that means he had such a massive spasm that his hands were under all of his intestines and at the base, pretty much like near the bottom of your abdominal cavity, and then nicks it.
Okay. So that's unlikely.
Unlikely unless he has the worst spasm ever, and also the biggest knife ever.
And he just had some shaky hands.
Yeah.
So he needed the knife. He needed the I don't care what knife from Blacklist.
Yes. So probably like a Cutco knife or something
right.
like that to do all that.
I noticed in that scene that in those few seconds, the patient had lost 2 liters of blood.
So that did not look like 2 liters of blood.
That didn't look like 2 liters of blood. We have about 5 liters in our body.
Correct.
2 liters that quick. Number one, is there a way to measure how much blood a patient has lost?
So we actually do estimate like that. Like during an operation, you'll actually see in their operating note estimated blood loss. So you can do that based on how many gauzes you've soaked. When you're suctioning, so there's always someone there with like a suction, and that suction actually goes to a canister, and that canister has a graduated
cylinder.
There you go. Something like that, but it actually has marks on the side of it telling you how many cc's of fluid have been lost, and you can convert that to how much volume you've lost. It's really hard to just go, yep, that's about 2 liters.
Based on what's on someone's shirt.
Correct. That's very hard. You don't know how much it got soaked. You don't know how many shirts it soaked through or anything like that. So once he lost all that blood, then the surgeon starts panicking and just starts doing the most willy-nilly compressions I've ever seen. But that patient still had a pulse. And I know he still has a pulse because we had subtitles on, and it said heart monitor beeping.
Yeah.
You can't have heart monitor beeping if you didn't have a pulse.
Right.
So
did he not need compressions yet?
No, I don't think he did. What he needed was fluids.
He needed fluids, and he needed them to clamp off whatever it was that he cut.
Correct. The anesthesiologist was calling for blood, but really you want to get the volume up because you want to make sure they can still maintain their blood pressure and perfusion. So usually giving fluids or something, which is much easier to get in the OR than blood from the blood bank. So I would give fluids right away just to try to maintain blood pressure, giving epinephrine or something like that so you can constrict the blood vessels so you can still maintain blood pressure. That's like the big stuff that you should be doing while you're trying to stabilize this patient.
Or alternatively, you can come up with a lie.
Yes, which is what they all did.
Right.
They all took off their single glove, which in the I know that's that's a very nitpicky thing, but usually when you're in the OR, you're wearing 2 gloves just in case if you snag on a bone or something like that and you tear through one glove, you're still sterile. So that way you can slide on another glove and be fine. But everyone just wore one single glove. So,
not like Michael Jackson style, but as in they didn't layer.
They didn't double layer, yeah. And you should always layer. It's cold in the OR. You want to layer anyways. And layering your gloves is actually a pretty important, safe thing to do, especially if you're in a situation where any small mishap can break sterility. Mm-hmm. So that was a big thing. So going back to what you were talking about, when everyone tried to blame everyone else or come up with a lie. So the surgeon blamed the anesthesiologist for not giving enough SIVO, which is an anesthetic.
Because the patient seized, which did happen.
I don't know if he seized. It looked like he just moved. Jumped up and moved, which means he wasn't sedated enough. Mm-hmm. Which, yes, bad anesthesiologist on that part. But then the chief of surgery says that he was at the end of a 30-hour shift, which I've never heard of any chief of surgery or chief of anything.
I thought he was saying that the anesthesiologist was at the end of a 30-hour shift and so made that mistake.
And even then, though, attendings don't, at least anesthesiology at this high level is what they're trying to portray it as, usually don't do like huge long things. They usually do shifts, like still 12 and 12s. Like, that's probably more than enough is what most of them would do. Especially in this kind of situation, if they're feeling tired, they should have had someone on backup already. So that's not a good excuse either. And then they're all trying to lie and stuff like that. But the thing that the chief should have recognized too is whenever you're in an OR situation like this, everything is meticulously recorded. Mm-hmm. Vital signs are automatically recorded. Can't go back and change it without actually showing that someone went in and changed it. When you give any anesthesia, they actually measure the volumes or the levels of the medication being given to. So that's actually shown. Anytime they would notice rapid blood loss or anything like that, or a rapid alteration, change in vital signs, it's all documented. Mm-hmm. So you can't really lie that the patient had a heart attack because you would have seen that on the cardiac monitoring. You can't lie that the patient had a pulmonary embolism because you would have seen other vital signs that would have indicated all of that before. And that should have been screened out before this was done. So you wouldn't be able to even proceed to this kind of surgery without having discussed all the risks and having a high-risk anesthesiologist or something like that on already.
And that was kind of the excuse that they came up with, was that he shouldn't have the patient shouldn't have passed that screen because he had a family history of heart problems.
Yeah, which that you can't. That's still at fault. Mm-hmm. There's no way about this. You messed up real bad.
Now, so there were 4 doctors in the room there. We had the anesthesiologist, we had the 2 selfie doctors, and we had the the chief of surgery,
the HODAD,
hands of death and destruction.
Correct.
Yeah, I like that neither of us actually know the chief surgeon's name.
I know him as HODAD.
Yeah, HODAD and Dr. Shaky Hands.
Yeah,
Captain Shaky Hands.
Yeah.
Wouldn't there be nurses in the room? And
well, there was that one nurse in the back who was just like, I can't believe it's happening, and trying to come up with a lie or something like that.
Oh, okay, I thought that was another resident.
I think that was
all residents.
I think that was assumed that there were some scrub nurses in there too.
Okay.
So yeah. So those nurses, they shouldn't be covering up for that doctor either. Mm-hmm. There's none of them should be covering up for each other, but I'm sure they realize that they screwed up real bad. So if any wind got out that they were taking selfies in the OR, they all would have been fired.
Right.
And you can't delete your photos. It's in the cloud.
So that's the opening. That shows that something is rotten in the state of Denmark.
And I wrote, what a way to start F this show after that first opening part.
Yeah. And that's kind of been his feelings throughout.
And that was only the first 6 minutes of this show.
Yeah. From there we move into... So which one of these is the resident that is the resident? So, is it Bright-Eyed and Bushy-Tailed resident?
I think it's supposed to be...
Jackass?
I think it's supposed to be Bright-Eyed, Bushy-Tailed Devin. Mm-hmm. Because, it's his first day and he's not keen to the world of medicine.
Yeah.
as Conrad.
Conrad, who
is a dick.
who basically should be wearing leathers and riding in on his motorcycles.
Yeah.
Devin, is the young geeky freshman throughout the show, except for in the very first scene where he's the suave debonair boyfriend who gets the Rolex as a gift from his girlfriend.
Where she said that's part of the doctor's uniform. I've never seen any doctor, let alone a resident, wear a Rolex to work.
Right.
Period.
I noticed just on Conrad, the douchey resident, the number of rings and things he wears is more like you're wearing a silicone ring right now.
Yeah.
For the sake of sterility.
I don't want to wear my nice wedding ring to work because on a daily basis, there's a lot of bodily fluids that I would prefer not to bring home if I can.
Yeah, exactly.
And wearing a Rolex, you're gonna bring home some stuff, and I don't want any of that stuff home.
Right.
So that was kind of annoying. It was kind of cute that he showed up to work, all dressed up, shirt, tie, wearing his Harvard tie.
That's believable to me.
That's believable, except for the fact that he walked in with his white coat still in the plastic wrap from the dry cleaner. Not believable at all. That white coat will not stay white for that long. Right. I remembered after my first year, my white coat was a nice, let's say, eggshell color. And
Mother of pearl.
Mother of pearl would be nice, but it definitely turned much more grody and yellow by the end of it. So that was not the way to go. Also, the first day, they all walk in, and it was like this nice harp reception in the atrium of the hospital. That is not how my first day... I think not how anyone's first day of residency is.
What's your first day of residency actually like?
Hey, figure out what rotation you're on and show up there. Congratulations, you're on your first day of residency. That's it. So mine was actually in a community clinic. So I just showed up, walked around really lost, asked the nurse or the receptionist at the front, like, hey, I'm Dr. Vane. I'm a brand new intern. I don't know where to go. Please help me. That was my first day. And I spent the rest of that day wandering around, not knowing where anything was, and constantly asking my attending, not another resident, what am I supposed to do? So that's the hard part. There was no free...
have an introduction to the chief of surgery.
No, not at all. I think the only nice thing was my attending, who was very, very sweet, made me some treats on my first day of work saying, welcome to being a doctor. And that was it. But nothing as fancy as this at all. Everyone was very confident on their first day. That is not... I would say 95% of the time, that is not the sense that I get from new interns.
Yeah, they don't even try to portray confidence.
No, it's just, I really don't know what I'm doing. I need help kind of thing. And
that's good.
That's a very good, humble thing to do. And most of the time these days, the first month, at least a lot of the programs that I've worked at, the first month of residency isn't even, they're not even touching patients at that time. We call it like a boot camp kind of thing. So you learn what to do, basic things, orienting yourself to the hospital, basic procedures, learning ACLS or PALS, which is just like life-saving kind of mechanisms or life-saving algorithms that you should be learning. So all these things just to get you ready to start working on your own. So you're not even in there running a code right away on your first day.
Right. We can skip over, I think, the introduction between Patel and Conrad. Obviously, Conrad's not going to... Your first moment with your attending... And he's not even what he should have been.
But he's not an attending. He's a resident who studied the chart of the intern and like knows everything and just calls him out on everything.
You're not going to start with sexual harassment in your first 3 minutes.
No. Holy crap. That was the worst. No pun intended. But they said the first patient was a patient.
Oh, I was good. I was going to that patient. Oh. I'm just talking about him just checking out the women in the gym.
I totally forgot about that part. Yeah. Being a total perv and a skeeve, basically. Yeah. Oh, no. That is a no-no.
But it's okay because he saves lives. Except it's not.
That is not a justifiable reason.
Exactly.
Not at all. That just kind of harkens back to the days of med school where my classmates would wear their pagers into bars and whatnot and then pretend to get paged. And either use that to impress or escape from a girl that they're talking to. So douches exist. I mean, that's not surprising, especially in the field of medicine where definitely there's a lot of God complex going on. Kind of like Conrad. There's a lot of a God complex coming on where only he can save lives and no one else can.
Well, yeah. He's got the tattoo.
Oh, the death before dishonor or something?
Well, he's got death before dishonor on his shoulder blades, and then he's got the staff on his forearm.
I've seen that tattoo on a lot of wannabe surgical residents in med school.
It just makes me think of Todd on Scrubs with his doc.
Yeah, that's exactly what you'll see. It's just, oh my God, this show has broken me so many times.
Patel's first interaction with a patient is a...
was it Croatian or something?
He's Croatian, only speaks Croatian, and he's presenting with something related to paralysis.
Yeah, so he had something called cauda-equina syndrome. So at the base of your spinal cord, you have all your nerves.
Where your wisdom is, where your wisdom hole is.
Obviously, where your... Oh, God, I totally forgot about the wisdom hole. But yes, where the wisdom hole is, there's a lot of... so your spinal cord kind of goes to a cone, and then it kind of frays out into a bunch of nerves. And it looks like the tail of a horse, cauda-equina. So one of the big things with cauda-equina is if you have sustained injury to that area, the first symptoms you'll get is numbness and tingling in your perineum, which is the area between if you're a woman, vagina in your butthole, or if you're a male, like your scrotum in your butthole.
It's the taint.
Your taint. Yes. Thank you. And you'll also have loss of...
Not medical terminology.
Still, I say balls at work all the time to explain body parts to kids. It's fine. But you also lose sphincter tone of your anus. But also you also can have bowel and bladder incontinence. So you'll pee up
so this was an injury that he was presenting with and not an infection.
Either that likely. Or you could have a tumor or something like that. But any kind of like pressing on that area can cause that. So the Conrad pimps Devin saying, what does this cause? And he says,
you've discussed what pimping is before, but what's pimping in the medical context?
Put in my place. So asking a question.
Asking a question Quizzing. That you don't expect the resident to know the answer, so that they feel stupid and know that they need to learn more.
Correct. So quizzed him. And he says early paralysis, but really the answer is if you don't fix it, you're going to get permanent paralysis.
So you need to fix it quickly.
Yeah.
Is that accurate?
Yeah. You need to fix it quickly. So really you need an MRI and all that stuff. Not serial rectal exams.
Right. So what they did was, we don't have time for an MRI. Put your finger up his butt. And then leave it there while you figure out what to do.
Yes. That's going to get you fired. Plus, if you had a patient with concern for cauda-equina syndrome, you can kick a lot of people out ahead of you in the MRI scanner line because this is
because of the speed.
Yeah. Because if you don't fix it soon, it's going to cause permanent deficits. Like, you don't want to lose butthole for the rest of your life. I mean, that's essentially one thing. And then also lower limb paralysis, too.
Yeah, also
bad.
Uncomfortable.
Yeah. So that's like the big stuff that you'd be worried about. So leaving your finger in a patient's rectum while your senior resident is going around, I don't know, making out with one of the nurses or something like that, that's rape.
Yeah.
That's going to get you fired. And that is just horrible. And the other thing you'll notice when you watch at least this first episode is there is no supervision of the residents at all.
That's why I didn't understand that he was a resident. I assumed that he was a fellow.
And he's not, though. He's just... But even then, like, a fellow still needs supervision from an attending physician. There's no way a resident can do all of these very invasive things without some kind of supervision. Because you don't know what's going on yet. You're still learning. That's the biggest thing.
Right.
So that's kind of scary. And it's kind of even crazier that other residents are consulting other residents for medical diagnoses. Like the lupus diagnosis, that one is basic stuff. And if you're a resident and you don't know that already, you're an idiot.
I feel like that scene only existed because of House. That scene was there because lupus was the holy grail for House.
That or sarcoidosis. Those are the two.
It was the holy grail for House. So they had to show it in the very first scene to show we are even more badass than House. Yeah. We got lupus right away.
Yeah. The other crazy part is they're all internal medicine residents, but they all act like
ER residents and ICU residents.
And pediatricians. And surgeons. So they do all of it. And they also have the audacity to go to the chief of surgery
and show up in his office.
Show him his office and tell him off and tell him how stupid they are. Me as an attending has fear. Mm-hmm. I can't even say a full sentence because it's so nerve-wracking with the thought. But like myself as an attending, I will not go up to the chief of medicine and tell him he's an idiot. That's like a horrible thing to do. There's a certain level of respect you should have for these people that are higher up. And yes, you might disagree with what things they do at times, but there's better ways to express it than calling him out and calling him an idiot or making up the name Hodad for a chief of surgery. That's really unprofessional.
It would get out.
And it's not an appropriate way to work in a hospital environment. You're a resident still. You're still learning. Mm-hmm. That's the most important part that they should be conveying in this part is like they're human. They're still learning. There's people that are trying to help and back them up. You don't know everything yet. No doctor knows everything.
So one of the things that Conrad said, this is going back a little earlier, was that he had the power to get Patel removed from the residency and that would tank his career. Number one, would getting removed from your residency tank your career?
Oh, yeah.
Okay, so that's accurate.
Because let's say you even if you voluntarily left your residency and you want to restart, you have to explain why you left, and then you have to get a letter from your old program director and all of that stuff
saying that it was on good terms and it wasn't because
you did something bad,
or were unprofessional or
correct
whatever.
Yeah, so getting kicked out of a residency though, like that's pretty serious stuff. Thinking back to my general residency, or at least the university that sponsored it, there were other residents that got removed from their program because they did shady things like trying to start a union without consulting all the people and under false pretenses and stuff like that.
Oh, wow.
And he tried to collect dues for himself.
Oh.
So that got him kicked out of his residency, and he can't get another residency because of that.
Yeah.
So getting kicked out...
I'm all for unions, but...
Yeah, but not under false pretenses, and also not collecting dues to buy a new car.
Right.
So that's kind of essentially what he did, and that got him into a lot of trouble.
Yeah.
So
that's question one.
Yeah.
Question one, would getting removed from your residency tank your career? Mm-hmm. Answer, yes.
Yeah.
Question two, could a more senior resident say, just like have carte blanche to say, nah?
No. Because there could be a number of reasons why. You know, like maybe that one resident doesn't like you, but everyone else thinks you're fine. It's all ultimately up to the program director whether or not you get removed from your residency. Conversely, it is also up to the residency director whether or not you graduate. So they can decide you did not fulfill the criteria needed to graduate. We feel that your knowledge is not appropriate to graduate. You need to do a couple more months before we can deem you an appropriate doctor.
Would that generally be something that would reflect poorly on you down the line, or would that just be
It can if you want to do fellowship.
Okay.
It can also reflect poorly if you want a job at a very competitive place.
Okay.
Because let's say I took the normal 36 months, I believe it is, to graduate, whereas someone else took 40 months because they had to repeat a couple rotations. They'll probably hire me over that person because I didn't have an issue with delay.
Unless there was a very specific reason,
like medical or something
like medical or
something. Yeah, usually it's medical is the big one, or family emergency or something like that. But yeah, so Conrad does not have carte blanche for any of that stuff at all. So later on in the episode, they're down in the ER again.
Mm-hmm. Why? Especially given how prestigious of a hospital it is.
Also, this hospital's huge.
It's huge. They've got enough donors that they have a VIP floor, which we'll touch on later.
Sweet God.
But they've got their residents are bouncing back and forth between oncology and ER and peds and wherever Gangrene Toe would be.
Oh God, Gangrene Toe, I don't know how he got into a patient room and not stopped in the ER. That toe would have fallen off already. Like if that toe was fragile enough that it was just a little tap and it fell off,
Someone would have looked at it in advance.
Yeah, and also when he lifted off the blanket, that should have ripped off the toe, and the smell would have been obvious for everybody already at that point. So gangrenous toe is not something that you'd miss, but also toes don't get that gangrene
and stay on
really. And the stink probably would have ruined someone's day already, that they would have been in the ER a lot sooner. Like, that's a very late stage finding. And that man should look a lot more sickly, because a toe that infected...
Not just the toe.
Correct. The patient should be much more infected, too. Like, that's just as a sign of poor peripheral vascular issues for that patient.
That we touched on the gangrene scene a little earlier.
Yeah.
I do want to talk about the doctor making out with the nurse. And before that, we had the resident... Patel went and complained to what we found out was a nurse about the resident he was assigned to.
Yeah, he snitched.
Yeah. Why is that an issue?
There's other people you can snitch to, but also you don't.
He went to her like she was in charge of the program.
Yeah,
though.
And she's not. But also, don't snitch to the nurse because...
Don't snitch to the nurse because you don't know what kind of relationship she has with the people she's working with.
Yes.
For example...
She's banging Conrad.
At work.
Yeah. That's a no-no.
I would think so.
Yeah.
I did enjoy the fact that she managed to lock him in, which means that they have rooms that lock from the outside.
Not safe.
Yeah. Not a fire code podcast.
No.
But...
You don't want your... call room to lock on the outside, especially if your doctors are all sleeping in the call room and there's an emergency and now the doctors can't get out to help with the emergency. That's bad.
I can't imagine any room at the hospital you would want to lock from the outside, because even
psych rooms.
Oh, psych rooms do?
They have you can actually kind of control a little bit, but even then we try not to lock them.
You wouldn't want it to just be a push button lock.
Correct.
That anyone could lock.
There really shouldn't be any locked doors in, like a push door lock anyways, in any kind of hospital room. Badge access room, fine, different. We do have badge access to like certain like trauma bays and whatnot, because you don't want looky-loos to come in and crowd the area. And you have badge access into certain departments like the pediatric ward. You can't just open that door that's locked from the outside. You can't go in. But
we've talked about the in-depth procedures like security in the NICU with Courtney.
Yeah, and also in Seinfeld where people just go around and rob stuff.
Yeah.
But can we just go back to, I guess, when all the residents go to the ER for this patient who has leukemia and now has fever?
Yeah.
So they kind of toss out a bunch of catchphrases or a bunch of medical terms, so it actually was correct. So if you have a patient with leukemia and they come in with a fever, the first things you want to do is get a line or access their port, which is where they get chemo, and draw labs and get a blood culture and start them on antibiotics right away. So him saying, let's get cultures, labs.
They said cultures from both arms.
Yeah.
Would there be a reason to do that?
So usually for adults, you usually want to get 2 blood cultures because there's always a chance of a false positive. So you want to confirm.
And so you want to be from separate areas.
Correct. But usually a patient with cancer, you would expect them to have a port. So you actually want a culture from their port, because the last thing you want to do is have an infection in a central line that's near their heart to have bacteria inside of it. Because if that's the case, you need to remove that and put a new one in.
Right.
And then starting broad spectrum antibiotics, which is also correct. But then all of a sudden he goes, let's get a CT of her head. Why? There's no neurologic changes. The patient's talking and mentating properly. That is not first line kind of things. You should be doing blood work first, because that's not part of your septic code. And then she also had like a syringe hanging out of her arm. Again, don't know why, but there's no blood or anything like that. And then they just kind of give her and treat her, and they treat her like she's a VIP kind of patient because it's Conrad's favorite patient. Everyone's taking care of her. We all have our frequent flyers in the emergency department that we know. We know their family. We've seen them a lot and stuff like that. So, yeah, we all are kind of attached to them and trying to make sure that we do the best that we can. I just don't get how later, when the patient starts decompensating, No one's in the room wearing like a mask or gloves or anything like that for an immunocompromised.
When she has leukemia.
Yeah, because she's immunocompromised. She's more prone to infection more than anything, and everyone in the hospital is covered in germs. Mm-hmm. So everyone should be wearing at least masks and gloves before they touch that.
As opposed to, at least taking off the tie was a good move.
Yes. Tie is a choking hazard. You get an angry patient, they will choke you with it.
I also heard infection hazard because they can't be laundered easily.
Exactly. I never wear a tie to work, and I don't think I've worn a tie to work since the second month of residency. I never wore a tie since then. But yeah, kind of jumping back. So the patient starts decompensating. Her blood pressure drops. Nick, the nurse that was hooking up with Conrad, asked if he wants to push Levofed. And the resident, or the intern.
What is Levofed?
Levofed is, think of it like a epinephrine kind of cousin. It maintains your blood pressure. It causes vasoconstriction so that you don't like keep tanking your blood pressure. So he turns her down and says, I want to do a central line. Central lines take quite a while. Like you have to be sterile, you have to drape them, you have to get an ultrasound, you have to do all this stuff to make sure that you have correct placement.
Well, good news. Mm-hmm. They didn't do all that stuff.
No, they didn't.
So the correct answer there would have been yes, push Levofed and then do the central line.
And then make sure you have 2 IVs that are working. Mm-hmm. If you can't get 2 IVs working, take out the intraosseous drill and just drill into the bone.
Which we discussed. Yep. That's the drill that goes into the bone to pump drugs directly into your bone.
And fluids, too.
And fluids. And fluids, okay.
Yeah, so you can actually pump fluids, too. So those are things you should be doing to maintain her blood pressure while you try to stabilize her enough to put a central line in. Because when you do a central line, the drape is so big.
Central line is a line that's going almost directly into the heart.
Almost directly into the heart. It goes into a main vessel that can deliver medications and fluids directly to your heart.
And the reason you do that is because that means that it's going to be dispersed incredibly quickly?
That, but also certain medications you can't put through a peripheral IV for a prolonged period of time. Because if you think about it this way, if you put epinephrine through a regular IV consistently, eventually that vessel is going to get irritated, clamped down, and to the point where you can't use it anymore.
Okay.
So you want
and with something that's so essential and so fast acting like epinephrine, you don't want that to happen and need to do everything to administer it all over again.
Well, it's not so much that, but it's you're playing long term kind of situation. Okay. So you want something that will last longer, and you're able to give higher volumes and also more caustic medications and more dangerous medications through a bigger vessel and a more durable line than just a wimpy IV. Because an IV is essentially just a straw
that goes into your vein.
Yeah. So that's why. And when you do a central line, you're draping a patient completely from head to toe almost. So if that patient decompensates, like stops breathing or anything like that, you can't see that really well. So you need to make sure the patient's okay before you do any of that, because if that patient decompensates, you have to take everything off. Now you have to do chest compressions, but you have a gaping hole in their neck that can potentially, burst and pour blood everywhere and whatnot, and that's not an optimal situation. And the way he did the central line is not how any of us were taught how to do central lines.
And how did he do a central line?
He took a scalpel and stabbed straight down.
Oh.
Yeah.
Okay.
And as you probably can guess, you don't want to stab straight down with a scalpel in a neck. Right? So there's multiple ways you can do it. The safest way to do it is using an ultrasound, putting a large bore needle in, using an ultrasound, finding the blood vessel, using a large bore needle, putting that into the vessel, put a wire in, and then gradually dilate the hole with dilators until it's big enough that you can pass the central line into it. Mm-hmm. The other way you do it is what we call cell dinger, where you use a blind needle and you kind of just aim in the direction and kind of dig until you get a flash of blood. And once you get that, that's when you pass. Hit. Yep, that's when you know you're in the vein. You pass a wire through, and then you kind of go from there. But you don't want to do that on an unstable patient, and that's essentially what this patient was. It's a septic, crashing patient in shock, and you want to stabilize the patient before you do something so dangerous.
Right. Yeah. Or you can just stab them with a scalpel
and then kill them quicker.
Okay.
Way faster. What other things? There were 2 other medical things that killed me. The code.
Right.
That was bad.
So there was so a patient comes in, drug user, You could tell she was a drug user because she had a green streak in her hair, purple streak in her hair.
Yeah.
So
Rebel.
obviously drug user.
Yeah.
And Conrad, the biker resident, immediately says, "No."
I like how you call him biker resident. He rode a bicycle.
He did ride a bicycle. No, because he should be. He's the Fonz.
No.
He's like a egotistical douchebag.
Yep.
Who the rules don't apply to me.
No. Which it definitely does tie in with this case, for sure.
Right. We had a patient come in who was a drug user. Everyone knew was a drug user, and he immediately says that when she's coming in with what looks like a psychotic episode, and he immediately says it's endo, which means...
So, I don't know what he was talking about for endo. The patient looked like she was withdrawing. Mm-hmm. When he said endo, that's not a term we normally use to refer to what he was trying to say, endocarditis. But when you say endo, we all think endocrinology, which it doesn't sound like a metabolic issue.
Endocrinology is...
like your hormones and stuff like that,
yeah.
So like diabetes or thyroid issues or whatnot. That's an endocrinological crisis. Mm-hmm. What he was trying to refer to is what she might have had is endocarditis, which is like infection of the heart. And he's pointed out Osler nodes, which is one of the things that I learned on, I think, my second week of medical school, where it's just like nodes on your skin, which is a indicative finding of endocarditis. And that's kind of where he was going down with that. And he bargained with her to get medical treatment.
Right. If you will let me give you antibiotics, I will give you Dilaudid.
And then they negotiated how much Dilaudid.
Right.
That is so inappropriate on so many levels. I would say you shouldn't be negotiating medical care like that. That's not safe for anybody. And you're potentially putting a patient, or you're reinforcing bad behavior.
You're reinforcing bad behavior, and that means that next time they come in, when they have a good doctor, which is an entirely different series.
Oh, God.
They're going to end up with not being able to negotiate for their care, and delaying things by hours.
At least, spoiler alert for this patient, she's not going to have that issue in the future.
That's true.
Yeah,
because she starts. I forget. Does she seize or does she?
She just drops.
And Conrad, the slightly more senior resident, says, "Patel, this is yours."
Yeah, he let an intern, a first day baby intern, run a code by himself. It's kind of crazy because he goes, "What's the first thing you check?" And he goes, "Rhythm." The first thing you check in a patient, we always are taught the ABCs. So airway, breathing, circulation, right?
That's actually something I knew,
Yeah.
and that's, most of a theater education.
Yeah, and you're supposed to look to see if the patient's breathing or not. That's way more important. So people are doing CPR really crappily. I think at one point they said you need to do CPR to the point where you can feel ribs cracking. Mm-hmm. The correct answer is about 2 to 3 inches deep, or a third of the chest, really pushing down. So then he goes, "Oh, what's the rhythm?" They say PEA. That's not PEA. PEA means pulseless electrical activity. So it actually looks like they're having a pulse, but when you feel for a pulse...
Oh, yeah, we've talked about that.
You don't have a pulse. That patient... But if you look at the monitor, that patient's in asystole, which just flatlined.
So you wouldn't have a rhythm of PEA.
Correct. The rhythm is asystole in this situation. We do have rhythm of PEA. Like,
okay.
I'll have patients...
Okay. So that would be something that you would call a rhythm.
Correct.
Okay.
Like... You'll look at the monitor, you'll have someone feel a pulse, they'll say, "I can't feel a pulse," and someone will just yell, "Okay, the patient's in PEA." Because electrical activity is working, but the muscles of the heart are not. Yeah. And then I do like how someone goes, "Do you want us to shock him or shock her?" And he goes, "No shock. This is not a shockable rhythm." So they actually did something right there.
Okay.
It's asystole. You don't shock asystole. But they were all doing such bad CPR. And then Devin Patel, bright-eyed, bushy-tailed Devin Patel goes in, does CPR, and does it super, super fast, and then brings her back to life.
Mm-hmm. After 26 minutes.
After 26 minutes. The other thing is, when everyone was doing CPR, if you do CPR in real life, you actually see it on the monitor, like the thing.
You'll see it. It'll look like a heartbeat.
It'll kind of look like a heartbeat, but it'll also go at the rate of how fast you're pushing. Mm-hmm. So it might be very disorganized and whatnot. So you'll actually still see that kind of stuff.
So you won't get the flatline CPR
unless no one's touching that
TV.
patient. Yeah, unless no one's touching the patient.
Okay.
If no one's touching the patient, you leave them alone and you see asystole, You only get like 10 seconds to check. Then everyone jumps back on the chest and continues doing CPR.
Oh, okay.
Yep.
I've learned things.
Yeah. So then the patient was down for like what, 26
minutes they said.
And they also said that her end tidal CO2 was like 15 or something like that, which means she wasn't breathing really well or making enough CO2. There was no way to monitor it. There was nothing on her face or anything like that. So there was just a guesstimate.
Right.
But I mean, the end of it still says patient is dying or brain dead.
Right. So that was right.
Yep. And then Conrad just really guilts him about it for saving someone who's essentially just a brainstem and whatnot. And I get it. It's a hard thing to do, but it's really hard to call a code when it's someone who's really young. Like it's been shown where the younger the kid or younger the patient, the longer you're going to run a code to try to save someone. It's just how it is. And especially in an in-hospital code where you actually see someone go down with efficient CPR, you can bring back a patient relatively at a high rate.
High rate of success.
Yeah. So, but then the patient's brain dead, it sounds like.
Yeah.
And towards the end of the episode, I'm surprised no one did brain dead tests or anything like that, checking if her pupils still work, if she can breathe on her own or anything like that. Conrad just goes in and tries to murder her.
Yeah. He goes in, he flips the off switch on the... This is the one machine that is keeping them alive.
Yep.
And it's off for a good 10 seconds, and then ex-girlfriend
comes in,
and so he switches it back on.
Yep. That patient's dead.
Yeah, I kind of gathered that.
Yeah. There's so many, like, cynical... This is actually one of the most cynical medical shows I've ever seen. Mm-hmm. Like, no one's good. Mm-hmm. Medicine's bad. Doctors all have a god complex. Don't trust anyone.
Right. We're not even getting into the robot surgery.
Oh, I don't know.
We can come back to that. That can be a bonus episode sometime.
Yeah. But I will say there's one more case I just want to touch on before like I go insane. Is this case where the chief of surgery is in on a patient that's coding too,
right,
and the patient has a very fast heart rate. Mm-hmm. So they push adenosine and all that stuff. So me hearing all that, I'm thinking this patient has SVT, which is supraventricular tachycardia, which just means your heart's just beating very fast because the electrical activity is just recirculating in a pathway it shouldn't be, and it's stimulating the heart to keep going. So they give him adenosine, which is actually one of the medications we use. And then all of a sudden Conrad just comes in and just
throws a bucket of ice.
But the patient's like in dire straits at that point. Just throws a bucket of ice, and then they wait like...
Nobody does anything.
No one does anything.
For a good 20 seconds.
And then all of a sudden the patient starts breathing and they're fine.
Right.
So that definitely is not how it works.
Okay.
I think we were talking about this during the episode. I think this happened at the end of my first shift as an attending.
So that's accurate.
Yes. So, no.
in that it happens on the first day of someone.
Fair. It does. So... Really, you can do ice.
Mm-hmm.
It kind of causes you to bear down, causes what we call a vagal maneuver, and it can jumpstart your heart. But the way we do it is we'll put ice in a bag and basically try to smother their face with the ice and suffocate them and almost try to suffocate them until they panic to the point where they take a big breath, and that can do it. You can tell them to try to push down like they're trying to poop. Mm-hmm. That's another vagal maneuver. Pushing on eyeballs. Not recommended, but it does cause the same thing. And then blowing through a straw can also cause that too.
I feel like we're just doing Mad Libs now.
I know, it sounds crazy, right? But you can only do that on a patient that's stable. This patient was not stable. Yeah, so you can do adenosine too, and that also stops the heart for like a good second. And it's scary because you'll actually look at the monitor, you can have a nice rhythm, and all of a sudden flatline. Mm-hmm. And you know it's going to come back, but that's the longest 2 seconds ever. And all of a sudden it just starts jumping up again. And the patients, when they're awake, they can actually feel like they're dying for a second, and then all of a sudden it goes back. However, if none of that works, and you've tried a couple rounds and the patient starts having their blood pressure drop, or they're getting altered, they're not answering questions or anything like that, you shock them. So that's actually when you actually should be shocking the patient.
We saw 0 shocks.
No shocks in this episode.
Which is surprising for the amount of badness we saw.
Yeah, this should have been shock, all day shock, the series. but surprisingly, no one's got shocked yet.
Yeah.
But I wrote so many times I hate this show. I think I struggled to get through this entire episode, and it was only one episode.
And our episode of the pilot episode of The Resident is longer than the pilot episode of The Resident, and we're skipping 20 minutes of the show.
Yeah, about like this robotic surgery with Hodad and all that other stuff. Like, this is really one of the worst medical shows, or at least episodes of medical shows I've ever seen in my life.
Well, next time I want you to suffer, we'll watch the second one.
That's going to be for a later episode, but I'm bringing along other people to share in the pain that I just shared too.
So, the human centipede bills itself as 100% medically accurate.
Oh, man.
If that is true, how medically accurate is the pilot episode of The Resident?
Look, they're in a hospital.
Okay, hospitals are real.
That's real.
Residents
are real.
Okay.
Certain things...
Harvard Medical School?
I guess that's real too.
Okay.
I mean, there are certain things that are real.
Okay.
But when they mishmashed it together, it made it very less real.
Okay.
What did I say Matrix was? It was probably low.
You gave it like a 40.
It's going to be about the Matrix level, to be honest. Like, a computer simulation is more realistic than the crap that I saw.
Okay.
Like, there were some things that were true. Like, some of the management for the first, like, it's like, in a...
Bad doctors exist.
Yeah, bad doctors exist. I will say they get the first initial step right part of the time. Mm-hmm. The follow-through is horrible. Like, the contact, great. Follow-through, horrendous. It's just horrible in general. So, yeah, I think 30 to 40 is probably where I would go with this. Like, that's me being generous. Like, the human centipede is way more accurate than this. Was it the wisdom hole?
Yeah.
Yeah.
No, the wisdom hole came from Matrix.
Oh, that came from the Matrix?
Yeah.
Still, way more accurate than some of the stuff that I saw today. Like, the ethical issues, the politics, the way people are acting, all that stuff, horrible. Like, these are doctors that should not be practicing medicine at all. So, I can't even think about how to start to make this better, other than the fact that please hire a better medical consultant, because a lot of the stuff they're doing is reckless, and it's getting to it makes it very dangerous, only because you're giving a false impression of what the medical community is like. And I think that's the biggest concern about at least watching the pilot episode, is seeing all these doctors practicing without supervision, seeing them doing very potentially dangerous and life-threatening things to patients, all at the risk of all for the sake of their own egos. And I think that's the most dangerous thing. And where I was always taught, the minute you think you know everything as a doctor is the minute you're going to make a mistake that potentially can hurt someone. No doctor knows everything, but everyone in here acts like they know everything. And that's the scariest part about this show. So, yeah.
Great. Normally I'd say, what would we do to make The Resident more medically accurate?
That's why I cut you off, man.
Yeah. So, thanks, folks, for listening. We will be back next week with maybe some better medicine.
Please. I'd rather watch, like, Ricky-O or something like that and joke around about that one than watch something that's so rage-inducing as this show. Honestly, it's so rage-inducing.
In the meantime, you can find us on social media and everywhere at Hi Everybody MD, and you can give us a call at 530-DOC-DORB with your thoughts on The Resident.
Awesome. Thank you so much.
Thanks, folks.
I can't watch the show anymore.